Hello, everybody. Good evening. This is Tunde Disu, and welcome to a wonderful episode of Become a Better Man. There's a treat in the house. We have a treat today. Today is going to be one of those days you will be happy. You will be glad that you are on this program. We have a special guest, like I announced last week. We're expecting a special guest, and guess what? He's here. Yes, he's here with me. But before I bring him on, let me go ahead and tell you a little bit about this great man. And I say thank you for joining us all the way from Nigeria. Thank you. I met this man, I think, around 2009. I had the opportunity, like you have today, to sit in a room where he was talking about this area of his specialty. And for 3 hours, my mouth was wide open. Sometimes you think you know something, and then you sit in the presence of people that actually know what they're doing, what they're saying, and it's a different ballgame. Today on this program, today on Become a Better Man program, I have the singular honor, the privilege, a lifetime opportunity to share this platform with a man I call Daddy. And I mean that with all respect and honor. He's a medical doctor, but not just a medical doctor. I have a list and I'm going to read it out to you. He's a senior consultant in gynecology. He's a specialist in reproductive medicine. He has over 40 years of medical experience. 40 years of medical experience. He's lived in the UK for over 34 years. He has 5 children and currently 6 grandchildren, and we're still counting. He's a specialist in assisted reproduction, and he has been that specialist as far back as 1983. He has published over 100 research publications and has presented over 100 various internationally recognized reports at international medical gatherings. We're not talking of just another doctor. I'm talking of we have in the house. Let me go. He pioneered, listen to this. He pioneered assisted reproduction in the Middle East. The whole of Middle East, he pioneered assisted reproduction. He's a fellow of the Royal College of let me catch my tongue. Obstetricians and gynecologists in the UK. Royal College of Obstetricians and Gynecologists in the UK. He's also a fellow of the Royal College of Obstetricians and Gynecologists in Nigeria, a fellow of the West African College of Surgeons. He's a graduate of the University of Ibadan. Where do you want me to stop? Let me know when you want me to stop, because I can continue. Ladies and gentlemen, if only I can see you, I will have asked you to get on your feet, put your hands together, and let's give a rousing welcome to my daddy, Dr. Daniel Imoideme. Thank you, sir. I'm going to turn the screen over to you and let you. I want you to start, sir, by introducing yourself to us, and then start to tell us what we need to know.
Well, good evening, everybody, and it's a pleasure to know that quite a number of you out there tuned in, to hear my humble discourse on this very prestigious forum. When I was asked, I did not hesitate to say yes, because I know the man, and he's a friend of the family, and I know him personally for his integrity. And I said to him, look, wherever I can possibly make any contribution that may well help even a single person, I will be prepared to come in and help. So here I am. I'm a Nigerian, and I'll always be a Nigerian. Graduate of Ibadan University of old, because I know what has happened, and well, that's a different story. Yes, I have been in reproductive medicine for quite a while. I started off as a senior research fellow at the Royal Free Medical School in London here, and there I did pioneer a lot of work which has become the basis of some of the things that are done today in assisted reproduction, what you will call test tube baby treatment. And I then proceeded to the Middle East, where, most people there, when I go to the Middle East, they call me the father of assisted reproduction in the Middle East. I don't know that I'm old enough for that name, but maybe because of what I did out there. And it's good to know that we did do a lot of work and contributed and pioneered quite a lot of things which were first time in the world, not just in the Middle East, but in the world. And I've patented some of those things as well. But I'm proud to be one of you and to be talking to you. I'm humble and hope that I'll be able to contribute to what you might want to know about male reproductive health, which is what the gentleman here, my host, has told me we are talking about today. So here we are. So do you want me to?
Well, Dad, just before you start, this is what I'd like us to do. As you can agree with me, this is a special program. So please, let us go and share this program right away. And please, I want you to send in your questions, send in your comment. I want this to be lively. And let me say up front, tonight's program is going to be slightly longer than our usual 1 hour. And I think you will agree with me, it is worth it. So as you are joining, let's go ahead. Let's go and share the program, and let's be involved. Dad, over to you, sir.
So then, when I was told by my hosts that we were going to talk about reproductive health, and I said, well, just male reproductive health is like saying, come and roof one side of my house for me and leave the other. I can manage with the rain on the other side.
The women will crucify me. We'll do the women one afterwards.
But you then said, well, we will do them later. But I said, okay, I agree. Yeah, we can do that later because it's a long story trying to put them together. But I will occasionally stray into that area as well as we move on from here, because you can never really discuss male reproductive health without actually adding to the female aspect of it. Yeah. Okay, so I start by saying, what do we define? Reproductive health is basically regarding things that have to do with producing children. God says, go ye and multiply. That's what the Bible says. It says, go ye and multiply and fill and populate and fill the earth and be glad and enjoy it. So that is the crux where we start from. What does that mean when that process is not happening or is becoming difficult? What do we define as a failure or inability to actually fulfill that particular instruction? In our modern world, we say that it is defined by the absence of a pregnancy happening in a couple or in a married family, in a married home, where unprotected penetrative intercourse has not resulted in a pregnancy, for up to 2 years in couples where the female is less than 39 years. This is the general definition, but as we move on, we find that this is continuing to change. When I was in medical school, it was something like 3 years. Now it's come down to 1 to 2 years. People are now beginning to look at it and say, look, if after 9 months nothing has happened,
then let's
really you should be asking questions. Okay, so this is where we are going. In the UK, we say that about 1 in 7 couples have a problem in the UK, in the United Kingdom. But that is a little different, from what it is elsewhere. If we look at worldwide, it is about 10% of couples who have a difficulty with establishing a pregnancy, let's say within the 1 year to 2 year period of getting married. In the developed countries, like I just said, the UK, it's somewhere in the region of about 8 to 15% when you look at all the various developed countries. But in the Nigerian sort of environment or developing country, not only in Nigeria, but Africa and other developing countries, it can be up to 35%. And the reason for that is obvious. Infections and so many other things that can go wrong, which therefore push up the rate at which this happens in our communities. Now, when you look at the pre-IVF, what do I call IVF? The test tube baby era. We used to look at fertility problem. I look at it when I was in medical school, for example. When a couple has no children, the husband says to the wife, oh, you go to the hospital. It's your problem. It's not mine. That's what, when I was in medical school, used to happen. And you saw mainly the wives. And therefore, we thought that infertility was disable to the female in about 70% of situations, and only 30% could be a male problem. But now we know that it's about the same, nearly a 50-50% sort of distribution, equal responsibility. And that is only natural because it takes 2 to make a baby. And therefore, there can be problems either way. And that's where our discussion today comes in, which is to do with the male aspect of fertility. When we look at fertility, it's a spectrum of from complete normalcy to absolute difficulty. That is a situation where everything is normal and pregnancies are occurring as easily as, the couple wants it. Or a situation where, for example, one party has a problem, but the other party is able to compensate for it. And therefore, there may not be an obvious picture of infertility or inability to have a baby. At the extreme is the situation where both couple have problems, in which case it's almost an absolute situation where we are talking of sterility. So we're looking at something that can be from either side, either the male or the female, normal or abnormal. So it depends on the combination for us to be able to begin to look at where does this problem lie and how do we go around to solving it. Now, the whole idea of fertility is the production of sperm by the male and the production of an egg by the female. And this then unite to form what we call the embryo that then develops in the female womb, having traveled through the tube into the womb to become a pregnancy. Now, there can be quite a number of things that can go wrong in either the female or the male. But today we are looking at the male aspect of the story. And what are the possible causes? I look at them from, am I born with this problem? And therefore, I've acquired it from birth, which in medicine we call congenital. Or have I acquired it after birth, whether as a baby, a little child, or as a teenager or an adult? So you can look at infertility from the point of view of congenital, born with it, and therefore that is the reason why I have a problem. Maybe it's a familial problem, or it's an acquired problem due to, I will again split that into various levels as we go along. Congenital issues account for about 5% of infertility as a whole. And most of that usually, you see more of those in the male area of infertility, where there may be problems with the tubes that carry sperms from the testicles and all that, or there may be complete absence of the testicle, or the testicle haven't come down at all from where they were in the tummy into the scrotum. And 95% are those issues that are acquired after we are born, either due to infection or due to some either operation or injury which we suffer, or lifestyle events. And again, we shall go through all of those as we move on. When we look at the congenital aspect, we look at, okay, congenital. What do you mean by congenital? Does it mean it's a physical thing, in which case, like I said a while ago, a blockage or a structure that did not develop while the baby was growing in the womb and so was born with that sort of thing? Or is it a genetic thing, which means it's something that runs in the genes in the family and therefore can lead to infertility? There are also hormone problems that are congenital. People may be born with problems with glands that sit on top of the kidneys that may be producing the wrong sort of hormones, or they may be born with problems with a gland in the brain that does not produce the right sort of hormone that helps them to develop into adulthood in terms of puberty, and then becoming able to produce sperm. So these are the various things. Can be anatomical, which means it is physical. It's a structure that hasn't developed. Or genetic. It's all in the chromosomes, in the genes, and it's been carried over from one generation to another. Or it is due to a hormone, which, may well be a congenital issue or something that may also be acquired. So that's the congenital aspect. Let's look a little bit into the acquired aspect of the male anatomical problems. The male anatomical problems I've just mentioned, things like when the testicles haven't descended. That's a physical problem. You're born with it. They haven't come down from the tummy where they were located when that baby was in the mother's womb. There can also be a structural problem where the opening of the penis is in the wrong place on the shaft of the penis rather than on the end of the penis, in which case sperm deposition in the right place during intercourse doesn't happen properly. And so becoming pregnant can be a major problem. In some men, the penis may be too small, what we call micropenis, in which case they cannot actually reach the site of sperm deposition. And so pregnancy may not happen. Some of them may get lucky and some sperm find their way, but it's usually a very difficult situation.
Dad,
Yes.
Dad, please.
Yes. What? Yes.
I don't know about you. I mean, what I'm hearing, I don't know if it's what you are hearing, because I'm not hearing anything from you. Apart from Griff said, oh my God. Or somebody said, this is very informative. Please, if you have not shared this program, help somebody. See, the Bible says, my people perish for lack of knowledge. And on this platform today, we are all going back to school to learn, to be more knowledgeable. How many couples do I know that have issues with getting pregnant? And like Dad said, the first thing is they're looking at the wife. What's your problem? How come you can't give my son a child? When actually, from what you're saying now, it could even be the man that
Absolutely.
has a problem.
It's a 50-50 chance of it happening.
Is Lord.
It's a 50-50 chance.
Please, go ahead. I just, please, if you have not shared the program, just go ahead and share it now.
Now, you may wonder and say, okay, you talk about genetic carryover. What sort of genetic problems are we looking at? I just go into two that are very common. A man is supposed to carry a Y and an X chromosome, which make him a man, and a woman carries two X's. Some men are born with only one Y chromosome, and you cannot function normally with just that one. Okay? And in situations where that happened, the lucky ones get to produce very low sperm numbers. Very, very low sperm numbers. And that can be a source of pregnancy not happening. Some men have two Ys plus an X. Now that means a double dose of the male Y hormone. These men also mostly don't produce any sperm. They usually are found to be the more violent type of men in society. If you were to look at the very violent criminal males, you will find a high proportion of them carry an extra Y chromosome. That is responsible for their behavior. But at the same time, fertility is low or non-existent. And if you were to examine this group of people, you will find that the testicles is the size of a peanut, groundnut, because we do examine men when they come to the clinic. So you find that that gives away some information to you to say, look, there is a problem here, and therefore we're going to do this sort of tests and all that stuff. And I did say about hormones, yes, there are hormones, of the brain that can cause infertility. But again, those are things that you will need to go to the lab to investigate and find out. Those hormones sometimes can tell you a lot of information. Where a man, for example, you examine them and they have normal sized testicles in the right place. The penis is normal. Then you begin to wonder, okay, if they have a blockage, are they actually producing sperms? The only way you can find out indirectly is by checking their hormones. The hormones we call FSH, F, S, and H. And the accompanying hormone is LH. Okay? We quickly check those hormones, and those give us an idea whether or not these testicles are functional. If they are within the normal range, then yes, those testicles are functional. Then we can begin to say, yes, this is probably a tubal problem, something to do with the tube that carries the sperm. If the FSH is high, which is what we will find in those who have the Y and XYY chromosomes, then we know that this is a major problem from the testicle, and therefore we're not going to have any fertility treatment available for them directly if they don't produce any sperms at all. So let us look at what else can happen. We're looking at the congenital. We've just talked about congenital. What about the acquired causes of infertility? They can be infective and non-infective. Infective being due to either viruses or bacteria. This is the area that contributes to most of what we see in the developing world, which is why infertility in the developing world is much higher than in the developed world, because the infection rate and the inappropriate treatment of infections when they happen can lead to infertility. And the non-infective things I will also talk about in terms of environmental situations, but we will come to that. The leading cause of infective causes of infertility, let's look at the male, things like bacterial. Gonorrhea, for example, is one. Any other infection, chlamydia is another very common one. Chlamydia is an infection that most people don't even know they have. They don't have symptoms, if at all any. And yet they carry it, and it can go on to disrupt the prostate in the man and cause blockage of the tracts we call the epididymis, and the vas deferens that brings the sperm out of the testicles. So gonorrhea is a sexually transmitted disease. Chlamydia has now been recognized as a sexually transmitted disease. And there may be other infection, bacterial, due to operations. After operation, there can be infections. Urinary tract infections that are not properly treated remain chronic and therefore create a problem for the sperms that are coming out. That in itself is a totally different, everything seems normal, but sperms are there, but they are not functioning as they should be because the environment in which they have been, is not, it's being corrupted when they are, ejaculated. There is the viral aspect, apart from the bacteria. The most common ones is mumps. Mumps is, I will always say, is stealth inducer of infertility. Usually happens in the early years of the child. When a 2, 3, 4, 5-year-old child has mumps, generally in the village or wherever, you will see some swelling around the neck here. Yes, and they'll have a fever. And that neck area is where the mother concentrates on. But actually, the mumps is actually doing a greater damage in the testicles. The mothers never really bother, never look at the testicles because they don't realize that anything is happening out there. So they're looking at the neck of the child that is swollen and painful, and the child has a fever, and they think, oh, my child is sick and got mumps, okay. But it's only later on in life, if the child knows or the mother can tell them that they actually had a problem like that as a child, can they then relate that to their infertility? Because mumps, when it affects the testicle, it wipes the testicle out. And usually men who have had that also have very small testicles. The other viral problem that can happen, luckily it's no longer so much with us, is smallpox. Smallpox causes blockage of the tract that brings sperm out of the testicle. Anybody, I mean, that will be in the older generation of people who may have caught it and all that stuff, but I had the experience of having a 75-year-old chap. This was when I was in the Middle East. He had tried everything to try and have a baby, and everywhere he went, they kept telling him he couldn't. He even went off to the US, and at that time, they told him he couldn't have a baby. And I had established a system then which could actually extract sperm from the testicle to treat any infertility situation. I then took a history from him, and the vital point was that when he was 18, he had smallpox. Smallpox. And because I saw the marks on his face, and I said, "Did you have anything, wrong with you at that time?" And he said, yes, when he was a teenager, he had smallpox, but it has nothing to do with his fertility. But I said that it has everything to do with what you have now, because it has caused a blockage to the passage of sperms out, into the penis. So sperms are produced, but they are not coming out. He eventually went on to have 2 children following treatment in my clinic, and I always say that it was an interesting character, because having those children turned him into a 75-year-old to a 45-year-old in terms of his behavior, in terms of his mannerism.
He became a child.
His joy, that was something I never forget him, and that's why I use him as an example of what smallpox can do. So history is a very vital part of what we do, taking a very detailed history of what have you had in the past and what may well have happened that could have caused the problem. All right, so we move on to the next, the non-infective areas are the ones that we have no choice about. We didn't, some of them we have no choice about, like environmental factors. When you read about male fertility, you will sometimes hear that the male is a disappearing species of human being.
Dad, please, before you go ahead. Now, I want us to eat this little by little. I don't want us to just gob it down, because we will lose the essence of the food that is being served. If in any way anything you have heard on this program today has resonated with you, or has made you to think, or has touched you in any way, I want to take the next 2-3 minutes to read some of the comments that you are contributing to this program. So I know a lot of people have been writing things, but I didn't want to disturb the flow. Please, I need you to, if you have written something, I need you to write it again. If you have not written anything, let us hear some of the comments that people are passing in the course of this, so that at least we know that what is being said here is ministering to you.
I'm very happy with that, because there's no way that I know how you feel, whether you understand what I'm saying, and whether it makes any sense at all to you.
Yeah.
It is the feedback that we get here that we can then respond to, and then give us a way of moving forward.
All right. Gift Blessing said, exactly, sir. Omonike said, now, wow, that is serious. Wow. Some of the things we're hearing tonight, if I had hairs, they would have gone curly. I mean, please, I need to hear from you. Say something, write something, so that we can know that what is being said here, this information that is being put in our hands. I mean, who could have, in the wildest of my wildest imagination, there is no way I could have connected smallpox to infertility. There's no way I could have connected
most people don't, that,
with infertility.
There
is no way.
Even amongst the medical profession, it's you need to be interested for you to really be able to make that connection, and to be a little more observant, and to look at the possible generational aspect. How old is this guy? Could he have been in that environment where he could have contracted this sort of illness? Whereas the younger generation, well, most unlikely, unless you live in some part of India, for example, where you still have the occasional sporadic, case of smallpox.
Please, let me hear something. Say something, somebody. Indeed, the Honora said she has shared this program. Thank you. Please, if you have not shared it, it is so vital that you do so. It will help you have a footprint of it on your own timeline. You can listen to it over and over again. But more than that, there are people in your contact that I will never know and I will never contact, and they will never see my program or see my timeline. But they will see it on yours. So it's important to go and share this. Sojo said, Stephen said, how true is the level of medical inquiries conducted nowadays to diagnose the cause of infertility? Omonika said, please, Baratunde, we have written a lot, so please read them from the top. Okay. Gift said, he has shared it.
Okay. Well,
let's continue, sir.
There's the question about how useful the investigations are. They're very appropriate if well harnessed in an understanding way. Investigation of infertility. I always say that medical practice is not magic. It's logic. You look at a situation and you put two and two together. You are taught to reason in that way, logically, that if A and B were to meet, then you probably have C. 1 and 2 do not produce 5, but they produce 3. So that is the logic of medicine, that first you start with history. Who is this guy? How old is he? How long has the infertility been? What about his family history? What other illnesses has he had before? Have you had any operations in the past? These are all then put together. And then you say, okay, I've ruled out A, B, C, and D. And this now helps me to target certain investigative procedures, which would either be in the lab, or sometimes we go into what we call biopsy situation, where we actually take a specimen from the testicle. So whatever investigations are done must have a purpose. And what is that purpose? To arrive at a diagnosis. And what is the purpose of diagnosis? To help us go forward with treatment if it is possible. So, yes, investigations are very important as long as they are done in a standard environment. That has its limitations. I know that in certain developing countries and so on, there will be problems of availability of the right sort of equipment, the right sort of personnel and experiences. Yes, these are limitations, but investigations are absolutely essential part of what is happening. I always say to people, a doctor without tools is useless to anybody. You can carry all the knowledge you have in your head, but without the tools of the trade, you are as useless to anybody as anyone who's never been to medical school. So that's the way it is. So then,
let's go.
Let's go on to the next phase. We've looked at the infective causes. The non-infective causes I usually divide into what I call iatrogenic. Iatrogenic means inadvertent situations. For example, a guy goes on to have a hernia operation, has a hernia operation, the surgeon does a perfect job, but he has actually created a bigger problem down the road in terms of reproduction. And we have that very commonly in our environment. A little child goes on and he has a hernia and all that. The parents take them to the doctor, hernia operation. And what happens? Later on in life, they do not produce sperms. And you then you examine them, testicles are fine, they are in the right place. You look at their hormones are fine, they are okay. Then you say to yourself, the only other thing that could possibly be happening is a blockage. And if there is no genetic issue here, then it must be related to the history. Because if you have taken your history very carefully and taken down that that child had a hernia operation at some point early in their lives, then you will realize that actually...
Yes. Wait. This is what you said. What I said is that I must take any man that wants to marry my daughter to a doctor before marriage, and no violent man.
Yeah. Okay. I tell you something, a bit of a... Do you know that by the time I left Saudi Arabia, both the man's family and the woman's family actually went on and made sure, one, that the man has sperms and is fine. Two, that the woman actually is ovulating and has regular periods. That was mandatory now before they got married. I mean, it became part of the society.
Wow.
A society that was very primitive when I got there in the mid-80s and didn't know much about what it was all about to look at infertility in the modern, aspect of it. That is still existent today. That they don't want to be faced with a situation where they get married because children are regarded very, very highly in their environment, in their community. So the boy goes on and he must have a normal semen analysis, and the girl must have a good ovulatory analysis to show that he's ovulating. So it's not something that is not unheard of. But I would say if you are taking the man, but better make sure your daughter has eggs in the ovary. I'll give you an example of a very, very pathetic situation that I had to face. This was in 2006. I had a young girl who 17, 18 years old. Her auntie was only about 39 and came in for infertility treatment with her husband, and we found that she had no eggs in her ovary. Okay, here we are allowed to look for, get donation and all that stuff, egg donation and all that. And she said, well, I will look in my family if there's anybody to donate eggs for me. Incidentally, her senior sister became menopausal at the age of 35. But they never really tied that to anything. Now, that senior sister had a daughter who was now 17, 18 years old. And she decided she wants to donate eggs for her auntie. Okay. She came in and I talked to her. She was still in higher school and, and she looked so young and all that. I mean, it's like looking at your own child sitting there and saying, I want to donate eggs to somebody. I felt bad, but what could you do in the circumstance? I explained it all to her and then told them what we need to do. We needed to evaluate her to make sure she had enough eggs in her ovaries. And guess what happened? She practically had no eggs in her ovary. She was just on her last leg.
At that age.
And it was one of the most difficult discussions I've probably ever had in my practice. To talk to a young girl, it's like talking to your own child, to say, if you want to get pregnant, if you want to have children, you got to either do it now or you forget about it. Otherwise, you'll be relying on egg donation in the future. It was tough. And she said to me, I don't even have a boyfriend. Not to talk, how can I talk about having a child? So it can happen. That's why I said earlier on in this program, it could have been useful to talk about the other side of the roof.
We'll come back. We will definitely come back. I don't know about you. We'll definitely come back.
So that's the thing that I said.
Auntie Kate said, wow, Lord have mercy.
So this is a situation that it can happen from both sides of the coin. We are all a little bit of female, a little bit of male in each one of us. Wow. Okay? So then, I talked about what we call the inadvertent situation, operations, injuries, for example, or like somebody who has an accident and broke the spine, and therefore the nerves that are responsible for ejaculation and all that are no longer functional, and so they cannot have children. So that's something they never really acquired on their own. They didn't go out to acquire, but it happened inadvertently. So that can happen. There is the aspect that we call immunology. Our body, the way our body functions is that we got a system that is like the soldiers of our body. They help us to fight off bacteria, help us to fight off viruses. When we get immunized for any particular disease, we develop antibodies so that when that particular virus or bacteria comes into our body next time, we are able to fight it off because we've developed antibodies. In infertility, we can also have antibodies. This is commoner amongst men than in women, although it's rare, occasionally you find antibodies to the eggs, but that's a very rare situation. But in men, it is not uncommon to find a situation where they have developed antibodies against their own sperms. That is immunological reaction to their own sperm. So they are preventing their sperms from functioning as they should. Okay, what usually happens is that the testicle is enclosed just similar to what happens in the brain, where the blood and the brain tissues never mix. Otherwise, there's a disaster. If for any reason, either due to injury, like when playing football or hockey or whatever and all that, there's an injury to the testicle, or there is an infection, that's an inflammation of the testicle, then there can be leakage of sperms into the body, into the blood circulation around the testicle. Normally, there should be no leakage whatsoever. The blood and sperms never really should meet. They never meet. Where this happens, what does the body do? It says, look, these are abnormal, especially as the sperms only carry one chromosome, one half of a set of chromosomes. Okay? They are either X sperms or Y sperms, and, they carry only one half. So they look abnormal to the rest of the body that carry a pair each. So what happens then is the body develops an antibody that says, look, these are not part of us. We got to fight them off, or we got to prevent them from doing whatever they're supposed to do. They coat the sperms, and sometimes they make them stick together that they cannot actually get on to do fertilization. Even if there are a large number of them, they can't fertilize an egg. That's something that can happen. Most men will say, and a man will go and do a semen analysis. The lab will say, oh, your sperm count is fine, your numbers, your motility, your that is fine. But he hasn't looked at the antibodies, which are actually chemicals within the seminal fluid that are actually interacting with those sperm and killing them off and sticking them together and preventing them from fertilizing an egg. So it's a bit of a delicate balance, doing all these tests, for girl and boy before they get married. Now, there is the lifestyle aspect of smoking, for example, is one of the very first lifestyle activity that we knew affects sperm function. Smoking. It was the very first of all lifestyle events that we know affects the function of sperm. It reduces their fertilizing ability because the body again because when you smoke, a lot of chemicals and carbon particles get into your system, and the way the body reacts is, this is not part of us. They generate what we call immune reaction as well. And those immune reactions tend to, they have an adverse effect on the sperm and the covering of sperm that help them to fertilize eggs. So smoking was the very first of human lifestyle activity that we know has an impact on fertility. Others are things like alcohol, excessive alcohol usage. Others include things like, for example, obesity. We know has a great impact on fertility because it has what we call an inflammatory sort of undertone, which also affects sperm function. And also the hormone circulation in the body is diluted, in which case the man is not able to produce as much sperm as the hormones determine that they should produce. And one other thing that we know affects, beginning to know very much, and which I'm working on personally has been of interest to me, and I've talked about it to my host, but I never really mentioned it actually, is snoring.
No, Dad, please don't say that.
A lot of men snore. I would say about 70% of men are known to snore. But it's not just the snoring. There is the aspect that we call obstructive sleep apnea. It's a disturbed breathing pattern that we now know accompanies about 50% of snorers. We now know that because of the inflammatory and immunological reaction that the body goes through, because when you have the obstructive sleep apnea, we call it OSA. When you have that, the body reacts violently to it, calling on all the resources because it's a blockage of the airway for a period of about half a minute while you are asleep. Without knowing it, you are not actually breathing. You are completely breathless. And then when you struggle to wake up, your body reacts like somebody who is, like when you see suddenly a lion burst into your room, how would you react? You are scared and all that stuff. The body calls on all those immunological reactions. And repeatedly, over years, these now begin to affect the fertility of the man. And because of the sleep disturbance, they are very sleepy during the day. They lose interest in sexual activities. They're very tired all the time. They are not interested in anything. All they want to do is just sit down and sleep, even during the day. And when they sleep, they start to snore and go through the same process again. So we now know that this also has an impact on male reproductive ability. I'm working on a book on this aspect at the moment. It's something that is exciting to me. I've been involved in it for over. We talked about it a while ago. I said, you know, I start and I drop it. I start and I drop, but I'm almost at the end now. So hopefully it will become available for people who are interested in knowing, you know, the ramifications of snoring, which is beyond, well beyond infertility. Now, environmental factors are those that we have no choice about. You know, we talked about smoking a while ago. Passive smoking. I always say to people, one of the things I would love to enjoy again is go back to my country and be able to walk the street and not have to smoke the smoke that I never wanted to. Because you go on the street of London, before you go 50 meters, there are 2 or 3 smokers, and practically you are smoking. You know, that's what it is. And passive smoking is now known to actually affect, although not as severe as a smoker itself, but passive smoking of a significant nature can affect the fertility of that person. Other things are, you know, environmental factors. We talked about pollution and all that stuff and so on. And we also talk about our water sources. Since the advent of the oral contraceptive pill, we know that the estrogen level in our water system has gone up. And males are beginning to be affected by this. And if we were, you know, there was a study that went back and looked at male, you know, sperm count 50, 60 or more years back and begin to look at the average today. The sperm count at that time was better. And when you relate that to the pollution level that we have in the present so-called civilized and modern world, you begin to realize that we're actually causing a lot of damage to ourselves. Whereas this is not affecting the females so much, it is affecting the males, and which brings me back to what I said earlier on, that the male is becoming an extinct species. We don't know whether the males will be here, you know, in the next million years. I don't know, but that's what the situation is. Now, I don't want you to be too disappointed about it.
Okay, now.
Now, let me look at, we did look at bacterial infection, chlamydia, gonococcal, mycoplasma is another very rare one. Tuberculosis is a common problem in our environment. Even in Britain now, tuberculosis is becoming a resurgent condition. We don't know, well, I mean, it's not that we don't know why. I think the right actions are not being taken. But even in the developing world, it's a major problem. Tuberculosis is still with us, and it does cause infertility in males and in females because of the blockage of the passage, the tubes, either in the male or in the female. Now, let us look at how chlamydia, which is one, I did say a while ago that the man who has chlamydia barely has any symptoms. We know that one episode of chlamydial infection will give rise to about a 12% infertility rate in a man. If he has 2 episodes of infection, it raises it to 40%, and 3 episodes about 80%, because then it disrupts the tubes that carry the sperm. So these are some of the things that and these are conditions that a man could carry around, or a female could carry around for years and years without actually knowing that they have it. And there you are. I mean, okay, let's look at emerging fertility factors. Diabetes, you know, is one of those things. Diabetes, how does it affect infertility? Diabetes that is not treated can destroy the nerves that actually are responsible for stimulating erection. So you could find that though there will be sperms in the testicle, though the hormones will be fine, but because those nerves have been destroyed by the very high sugar levels that have been in circulation for years and years, the man loses the ability to have an erection and therefore cannot have proper intercourse. I did talk about alcohol. Alcohol is one when it's excessive. Recreational drug use, it's another lifestyle event. We know that men who use marijuana, hemp, Indian hemp, are more likely to end up without sperms at all. I did mention about snoring, and of course there's a lifestyle event, that is occurring beyond all of this, that a lot of people are postponing childbearing. If you were to look at various societies 100 years ago, an 18, 20-year-old boy would have been married, and a girl of 16 would be getting married. But if you look at the pattern of things today, that is moving on. You'll probably find that in the world today, the average age of a man getting married will be over 30. And the average age for a girl will be somewhere almost in the same situation. And in the Western world, it's getting much, much higher because of career. They want to pursue their career. They want to get to somewhere where they can earn enough to look after their family and be independent financially. That in itself, it's a lifestyle choice that can lead to problems, because we know that men over the age of 40 having children, just like women, have an increased chance of having an abnormal baby. It used to be said women, but it is not only women. Now we know very clearly that there is a pattern of abnormality in children born to men who are 40 years and above at the time of conception.
Wow.
Whereas they may not be as obvious initially as it will be in the case of a female, where you have Down syndrome and Mongolism, as we call it generally. There are specific anomalies that we now see coming through in males who have delayed childbearing to later years in their lives. You are are you wishing you hadn't done this?
No, I'm glad. I'm glad we're doing this. I don't know about you guys out there. I mean, I could sit here for the next 3 hours. I won't get tired of this, because what is affecting us more than anything is what we don't know. Bishop David Oyedepo said, there is no mountain anywhere. Every man's ignorance is his mountain.
Yeah, absolutely.
And isn't it true that the Bible says, my people perish for lack of knowledge?
For lack of knowledge, ignorance. Yeah. Well, our Lord was killed out of ignorance because the people refused to know. That's the thing. And he prayed for them. From that point on, he saw the ignorance in what they were doing. Yeah. So,
we're going to take the next 10 minutes, and then please, if you have any question, can you email it? Don't post it. Email your question to theadmirals@yahoo.com. If you have any question, you have 5 minutes to email your question. The email address is theadmirals@yahoo.com, so that Dad can at least try and answer a few of them before we close.
Don't make them too many.
No, we only have 3 minutes, 5 minutes maximum for the questions. Whatever comes in after that, we'll just have to bank it for another day.
Okay, let me just run through areas of investigation, because, we've been talking of causes and all that stuff, the sad stories and all. Okay, what do we do about all of this, you might say? The first thing, as I indicated earlier on, is a good history. A A good history will give you an idea what sort of problem, even without any investigations, you begin to see your way in the direction of what this could be due to. So, you look at the age of the person, whether male or female, you begin to relate that to their fertility situation. What should it be at that age? You look at past medical history. Have they had any medical problem? Have they had any surgical procedures? Have they had any accidents that has required major surgery on their backs and so on? Then you look at their social lifestyle habits, smoking, alcohol, tight clothings. Tight clothings, I know they are fashionable, tight jeans and all that stuff, but they may not be doing the male a lot of good. So we know that the testicles are outside of the body at 2 degrees lower than the body, because that is the best environment for sperm production. When the temperature of the body rises, or the testicle rises above that level, then sperm production gradually diminishes. Which, for example, is why we also look at occupation. Long-distance drivers, truck drivers, lorry drivers, and all that stuff have more infertility problems than people who are just ordinary, who just walk to work and don't do those sort of occupation. People who sit for long, long hours, because the temperature at which the testicles are enclosed is above the 2 degrees below which they should be, the temperature of the body. So that's a very important thing, that fashion, we should take it to a certain extent, but also remember that it does have some implications, especially when it comes to the males. Body mass index, again, I talked about weight, obesity, and all that stuff, and what it can do in terms of affecting infertility. Now, let us look at what are the normal parameters. What is the normal? I want us to look at, just a minute, something here going wrong.
Oh, it's gone this way.
Yeah. Now, I want us to look at what do we do once we've got the history. In a man, what are we likely to do? There are those that we call the non-invasive, inexpensive tests. And the first and the most useful of those is a simple semen analysis, a sperm analysis, which will tell us, are there sperms or are there no sperms? Before a man goes for that test, he should have abstained from intercourse for at least 3 days. And he should use no soap. It should be produced by masturbation. Where that is not feasible, which I know is a problem with black people. I've seen it, Nigerians, Ghanaians, West African people, most Africans, masturbation is a major problem for them. And because of that, I think there's a condom that is now developed that they can use, so they can still have intercourse with their wife, but not ejaculate into them, but into that condom, and then bring that condom to the clinic. But that's the first thing. 3 days of abstinence, ejaculation, no use of soap, no use of water, because all this kill the sperms, and then you get a wrong picture. And the World Health Organization tells us that there should be at least 20 million sperms per meal. For every meal, usually the volume of sperm should be no less than 2 to 5 mils. It can sometimes be up to 10 mils, but no more than that. When it's excessive, then it can also be a problem in itself. So, the amount of sperm per unit, per meal of sperm, should be about 20 million. So you can see that sperms are very, very tiny, much, much smaller than eggs. And the total sperm numbers in a whole sample of sperm should be no less than 40 million. And the number of sperms, the percentage of sperms that are moving should be no less than 40%. And what we call progressive sperms, those that are fast moving, should be no less than 25%. And we should have no more than 70% abnormal sperm form. Abnormal sperm form means they are misshaped, they have more than one tail, or they have more than one head, in which case they can't really be useful to us at all. So there are, parameters that we look at. And we also look at the number of what we call white cells, which are blood cells that are protecting usually the soldiers that I talked about earlier on, for immunological purposes, that are usually added as the sperm comes out of the testicles through the prostate out of, to the penis. Now those cells should be no more than 1 million per mil. If they are more than that, then it means there's an infection in the prostate, and the prostate is adding an excessive amount of these cells, which can actually adversely affect the fertilizing ability of the sperms. So these are this is the central foundation, the pillar of investigation. The first thing that tells you, here we are, there are sperm, they are in good numbers, they are good shape, they are moving well. These are the parameters we look at. And then you can move on from there. If they are low in number, then you begin to look, okay, can you correlate that with the size of the testicles when you examine them? Can you correlate that with the hormone level? Because then you will be going to do their hormone to see whether their hormone level will tell you a little more story. Okay? So these are things, if the movement is low, less than 40%, say you get 20% motility or 10% motility, then we may not have enough sperm getting to where the eggs will be fertilized in the fallopian tube. In which case you begin to find out, is it because there is an anomaly in the sperm itself, in the head, in the tail, in the middle piece of it? These are all things that we look at. But they shouldn't concern you. Your doctor will be able to tell you what exactly they are seeing. Your fertility specialist should be able to explain to you if your general practitioner cannot do that. I think...
Dad.
Yes.
This is what I'd like us to do.
Mm-hmm.
I've got one question.
Yeah.
But before we take that question, is there any way you can summarize this whole thing?
Yes.
So that I can use that time to quickly check on the comments that people have been passing, and also to give you time to answer this question.
Okay. The summary of all that I've said, and which I always say to people, is that there's only one function for a sperm. One and only one function for a sperm. Doesn't matter how good it looks, how fast it swims, and whatever the numbers, and that is to fertilize an egg. If it doesn't do it, then there's a problem. The rest is history. We begin to go through looking at history, looking at investigation, looking at what may be the cause and all that stuff, and then trying to tailor a treatment to that situation. I haven't talked about treatment today because, as I say, one side of the roof is still open. We can't be treating when there's still water coming through. We can't be treating when one side of the roof is still open.
Yes.
So hopefully, if we're going to have some time in the future to do the other side of the roof, then we can comprehensively look at what is there available for us. But if I were to mention about the male, there are some options. You can look at, is this a problem with blockage of the passage? Is this passage amenable to repair? There are investigations you can do to locate that blockage and see whether it is amenable to repair. If it is a hormonal problem, can you actually, replace some hormones? And there are men who have benefited from hormone injections and have gone on to have normal reproductive life. If there was no sperm at all, then the situation is a little different. Then we begin to discuss, what do we do? This is where faith, your beliefs and all that will come into play, and you then make decisions how you go, and you say, look, I'll live with this or not, or I will look at exploring sperm donation, which is something available in this country, and I'm sure it's also available in Nigeria.
I want to believe that you have enjoyed, you have learned, your mouth has been left wider than mine, sitting next to Dad here and hearing all of this. I don't know if you've noticed, most of the time my mouth was just wide open. I don't need to ask. We're going to have another session, Dad. No, seriously. We haven't even finished dealing with the men, and the women we haven't touched at all. And I'm already in the doghouse with the ladies, because we have ladies on this program.
Let me say something. We are working on something because I feel that you should participate at greater depth by me being able to show you things on the screen, and we are going to be working on that, and hopefully we may succeed in getting that happen.
We will succeed.
So that I can show you, not just by talking and you just hearing. So your eyes can also see a few things of what I'm talking about in terms of maybe pictures, in terms of what actually happens, and that may help make a lot more sense. Because I always say, for example, when it comes to eating, if my eyes haven't eaten, then sorry, my mouth is not going to eat.
No.
My eyes have to be satisfied that this food is there.
Yes, sir. Sir, I'm going to come off this.
Okay. Yes.
We don't need this anymore.
Yes, that's fine.
Now, this is the question that I have here. This question is from Stephen Ikebua. Thank you so much, Stephen. And if you still have one more chance for one question, just one question, email it to theadmirals@yahoo.com. If you email it now, we will treat it. theadmirals@yahoo.com. One question. This is the question from Stephen. Based on all this information on these numerous causes of male infertility, in your opinion, sir, how thorough are the inquiries conducted nowadays to diagnose the cause of infertility in males? Up until now, I have only heard about low or no sperm count. So the question Stephen is asking is, all these areas that you have opened up to us today, are they all being investigated when they are looking at infertility in male? Or are we just being told, oh, you have no sperm count or low sperm count, and that's it? I'll let you answer that while I attempt to.
Okay. Now, the thing is, it depends on what is available in your environment and the capabilities of whoever the care provider is. When a male walks into my clinic, for example, he's going to have the full works. He has given his consent, and I will explain all of this to them. These are all discussions I have with any male who comes to my clinic, for example. These are all that you heard today. I will discuss with them history, and then what the investigations can be and what they are likely to be. Then they say, yes, I'm prepared to go for this. And then you do that. And when you've done those investigations, you bring them back again to discuss what you found. First, the semen analysis. It gives you an idea what other details you need. There are other basic routine tests which are not directly related, but in preparation for treatment. But all of this that I've talked about to you today are routine tests that should be carried out by any clinic that says they are treating infertility or looking at reproductive health of a male. There are males who come to your clinic and say, look, I just want to check myself out. Yes, you're not going to check one half of the story and let them go away not knowing what the other half is. No, you give them the whole work and say, look, here it is, you got all this, you got it's normal, it's abnormal, and this is what is abnormal. It's not just a simple question of you have sperm, you don't have sperms. Yes, those are extremes. Those are extremes, and I did explain that earlier on. Extremes, yes, do exist, but in between, there's a spectrum of, I did say 20 million a while ago is what is suspected, but a guy who comes in with about 15, 10 million, we may be able to tailor some treatment for him depending on what we find with the wife. Okay? So that's where it's two, the two have to actually collaborate or come together to create that environment that you need for helping them through. So every investigation is not just a semen analysis, sperm or no sperm. There's so much more than that. If there are no sperms, it doesn't mean you can't have a baby of your own genetic makeup. There's still a lot more that you can do. So let us leave it at that and say, okay, look, every clinic should be able to do the sort of tests that discuss the sort of discussion I've had with you today and do the relevant tests related to the areas that I've mentioned. Yeah?
Keep on, sir. I'm coming.
Yeah, I mean, what else? There was something I was going to say that once you've done your test, the semen analysis, one test is not just enough. If I find that the semen analysis, I said 20 million or more, and I find this is 10 million or 15 million, I will say, okay, come back in about 2 months and do another test for me. Then I would look at those tests. You're looking at consistency because there can be variation. I'll give you an example. If you were to do semen analysis on the same man every week, there will be episodes of results when his semen count will seem to be below the normal. That is where you must have at least 2 samples minimum to be able to say, okay, look, this is the pattern we have, and therefore this is what we think we have in our hands. All right?
Right, I'm back. Let's go through some of the comments that we have here as quickly as possible. Gift Blessing says, ignorance in most cases is the reason for premature death and so many other health challenges, not the devil. That's very true.
Yes.
Sojo has sent an email. Omonike said, we are glad, sir, that you are giving us this information. Thank you so much. Thank you. We appreciate you. Sojo said, thank you so much for this episode. Ezinwa said, this is a topic that is always neglected, and it is well needed, especially amongst our African societies.
Yes, I appreciate that that comment. It's something that has been very dear to me. The fact that we in Africa love children, and infertility is a major blow to any relationship, any marriage. It has been something that has been close to my heart, and I try to educate where possible and give advice where possible and do whatever as a specialist I can whenever I meet anybody whom I find I can help in that regard. It's a major issue, and ignorance is one of the things that we need to conquer. All the various One of the problems that I do have in our environment is that patients are unable to challenge their doctors. That is one of the things. It's a one-sided discussion, and I find that disheartening. Because when a patient walks into a doctor's clinic at home, they are trembling virtually, because they're going to have a one-sided discussion. It's not a discussion of, this is your body, you make the decision. No, the doctor makes the decision and tells you what to do. Whereas I have come to see a different kind of practice by practicing here for so long, which is you give the facts to the patient makes the decision, and they can challenge you, and you advise them to go and seek a second opinion based on what you have found, because it's the facts. The doctor should not feel reluctant to tell you to seek a second opinion, not by way of aggressive communication, but by saying to you, look, it's your body, these are what decisions have been made, these are what advice has been given. You may seek a second opinion. If you think we can help you, you can come back. That, to me, is the biggest problem in our environment, that we are unable to discuss with our doctors. We go in there to be talked to. That's maybe you understand what I mean. I have seen it quite a lot, and it's unfortunate. Yeah.
Right. Somebody said, where is it? It's going down so fast. Lack of information has really done more harm to a lot of people, especially the women. That's a gift.
I agree. Still the infertility burden is still skewed heavily towards the women in our environment, which is still unfortunate. That's nearly 50 years on, from when I was in medical school, and we still have the same sort of approach to infertility, and who is responsible and all that. It's ignorance. I'm not sure how to deal with it unless through forums like this, where people begin to understand what the real facts are. It's a difficult one, but there we are. Yeah.
Omonike said this is a lot of information. Give them, may God bless you, sir. Nkiru said almost every infertility in Africa is tied to the wives. We've covered that. That's very true.
It's a truism. Yeah.
Is it possible? Man. Somebody said, please, Brother Tunde, help me tell the doctor that I still want born Peking without a man's love making. Please advise me, sir.
It's an option. Like I said, it's a matter of individual choice and individual faith. What you believe, what you think you are prepared to do in your life and all that stuff. Yes, it is possible. It's very, very possible. That's not an issue. It's not, the choices are there, the options are there, there are many of them, and there's no problem. Yeah.
Good. I'm just trying to, there's so many of these that are just about the same things. I didn't want to just keep repeating the same thing over and over again. Yeah, when you were talking about the young lady that was between 17 and 18 years, somebody said, now, wow, at so young age?
Yes. Unfortunately, we are not looking at the other side of the roof. There's a lot of information. And that, again, has been an area that is of particular interest to me. A woman from conception, from inside the womb, right up till death, what happens in their ovary. You know, that is something that we hopefully someday, if we do have another episode of this whole stuff, cover, and because it's something that every female, there is a test that you can do. And I am an advocate. I think a few years ago, as far back as 2009, I and another lady who was doing a senior lecturer in University College of London tried to push for a situation where every school, every girl at the GCSE or is WAEC, isn't it? The WAEC level. When they are coming out of, is it something 2?
Yeah.
Whatever 2.
SS2.
SS2. When they are coming out of SS2, which is equivalent to the O-level stage here at the age of 15, 16, they should know, they should be educated about what the ovaries in a female look like and what ovarian lifespan is, because God, for his own wisdom, has created men and women slightly different in that respect. A woman, as far as we know now, although there's some research coming through that some women may well produce more eggs, but we know that a woman's egg, the number of eggs in her ovary, are determined at the 3rd month of conception, when she's in her mother's womb. Jesus Christ. And they continue to diminish from then on till she gets to menopause. And depending on how many she starts with, that will determine when they finish. That's an area that I particularly love the females to know about that. In the environment I worked in, I've worked in here, I've encouraged every female who was not married to go, even within the fertility clinic, I've encouraged them to go and do what we call anti-Mullerian hormone test, AMH. It tells you where you are in terms of your ovarian reserve. That tells you, have I got time? If I say I want to do a PhD and then go on and become the dean of the medical school or before I have a baby, do you have the time? Whereas for men, as long as the testicles are producing sperms, as we already said, and nothing drastic has happened to those testicles, they will continue to produce sperms, new sperms, until the day they die. Women don't produce new eggs. That's what the science says as of now. Okay? So, it is very crucial for females to have that knowledge. And I've always said it is good for grandmothers to know it. It is good for mothers to know it. It is good for the children to know it. Daughters, mothers, grandmothers should know that they have a finite reserve of eggs in their ovary. And when they are finished, they are finished. And each one of them is endowed with a certain number from when they are in their mother's womb. And they continue to diminish from then on. Okay? So it is important for them to try. I encourage it. I encourage every female who hadn't been married within the department I work in, go and do it. Even those who are embryologists working with me, they don't want to do it. But I say, look, you want to know what your options are. You may be sitting here thinking all is fine. But supposing it's not fine and you need to do something, the option is now there for females to freeze eggs for the future, to freeze their eggs for the future. But again, do we have the facilities in truth at home? I happen to have worked on pioneering the technique for freezing eggs somewhere between 1983 and 1985, which is still being used now. But I don't know that we have the facility at home. People may say to you, oh, come, let us freeze your eggs. Yes, it is possible. They say that, are they able to do it? That will be my only worry. Yes, it is possible to do that test, find out where you are, try and freeze eggs, and say, look, I can freeze so many eggs. Here we say, if you're going to freeze eggs, you must freeze at least 25. That gives you a chance of at least having 1 or 2 babies. Because some eggs will not be good, some will not fertilize, some will not develop into good embryos. So you have to look at your options there. So it's a difficult one, and I particularly empathize with females for that particular reason in terms of...
Sorry, Dad.
Yeah.
They want you to repeat the name of that test that you just mentioned.
AMH. A for apple, M for money, H for house. AMH. Anti-Mullerian hormone. You can write it, send it to them.
I'll send it to you. I will put it on my page.
AMH.
Well, Dad, I think we could be here till Jesus come at this rate.
Yeah, we have only done with about a third of what we should have been dealing with.
Now,
we haven't done with treatments.
I'm going to beg your indulgence that very soon we will be requesting your presence again on this program, because this for me, I don't know about you, but for me, I want to know more. I'm a father.
Yes.
I have a son and 2 daughters. And the more I know about all of this, the more I will be in a position to support my children, to educate them, to inform them, to help them.
One of the first things, I know, I'm not trying to, one of the first way to look at what your ovarian reserve could be is look at your family history. When did your mother become menopausal? When did your grandmother become menopausal? When did your auntie become menopausal? These are indications. If they went into menopause early, then you are really at a high risk of doing exactly the same, because you are from the same gene pool.
Thank you, sir. So we will be seeking your presence.
Well, we'll see how that works out.
Yeah, we will see. We will see.
Anyway, you all enjoy the evening, and I'm happy you've been a very good bunch, and I hope you have benefited. I am not sure how much I've given. It's been a lot of talk, but hopefully you've gained something. And God bless you all.
Dad, thank you, sir. I appreciate you. I honor you. Thank you.
Right.
Thank you, sir. Well, quickly before I don't know if I'm going to sleep tonight. Please, let me use this opportunity on behalf of everybody that has been part of this program today. And please, if you have not shared this program, I am begging you, go and click your share button. Somebody sent a question that, how can I get somebody else to watch this program? It's simple. Click the share button. You will have a footprint of it forever on your timeline. And you can even send it. You can share it to your friend's page. So please, if you have not shared it, go ahead and do so right now. On behalf of all of us, I want to thank Dr. Daniel Imoideme for tonight's program. It has been an eye-opener, for lack of better description. It has been educative, informative, impartation, and everything rolled together. And sir, we want to say thank you.
Thank you very much.
And definitely we will have him again and again and again for as long as we need it, because what we're hearing here is very rare. You don't come across this depth and quality every day. Please, if you have not registered for the Become a Better Man seminar, we only have 2 weeks. If you have not registered,
the women should protest. Become a Better Woman seminar as well.
Dad, please help me. I'm already in the doghouse with them. Please, let's go and register. It's free registration. I have posted the link on the Facebook on my Facebook page. I've emailed it. I've sent it by WhatsApp. I've tagged people. Please, all it takes is 2 clicks of the button or thereabout, and you are registered. Please, because of catering and administration, we need to know how many people are coming, and share it with your friends. Tell your friends about it. Well, enough of me rambling. Thank you to all of you that have been on this program today. Thank you for your time. I know it's longer than usual, but I think it has been worth the time. Thank you so much. And until next week, when we meet again, this is Tunde Disu saying it has been a privilege to have you on the program today. And on behalf of all of you, and on behalf of myself and my family, we want to say big thank you to Dr. Daniel Imoideme. Thank you, sir. We honor you.
Thank you very much.
God bless you. Until then, see you next week. Thank you. Please share click the share button and let it go viral. Everybody needs to hear this. Thank you. God bless you. Good night.